Please feel free to share your screen.
All right. Okay.
Awesome. Great. Yeah, so I'll invite Dr. Amanda to just introduce herself and then we'll start off the session. Feel free to type in your questions in the chat box. We'll have the Q&A at the end of the session after the presentation. And also feel free to raise up your hand at the end of the session to just ask any question that you would have, even as we go through breast cancer awareness. So thank you, Dr. Amanda. Feel free to share your screen.
Just in a minute.
But leo anakaa pisto. Haya wanamtoa. Wameamua tu
I
kumtoa
request
hivyo.
us as we log on, we mute our microphones too,
I think
so that we don't interrupt the session.
Just share the whole window that you can see. I think let's start by a little activity here. So I'll put on a QR code that you will be able to use, and then let me know. I'll be able to see your responses from my side. So just feel free. It is not. I won't be able to know who is who or who has answered what. All right. So using the QR code above, I think you should be able to see it now. Can you see a QR code?
Yes, it's now showing.
Yes. So just scan the QR code for those ones who can scan, and kindly just attempt the whatever questions that it gives you there. As we wait for people to join, just do right that. It's a very simple exercise, very few questions there. I give it right about, time is it? Right about 2 minutes should be able to be enough for people to just attempt. Kindly scan and then attempt the question. You can see a few responses coming in. Okay, I think that's right about enough. I think I can now project the other bit of the screen. Kindly let me know if you can see anything now on my screen. Can you see the presentation now?
Yes, you can see it.
Fantastic. Okay, I hope this doesn't. All right, so I think I will go straight onto the topic of discussion for today. I hope, Yvonne, we have enough quorum.
Yes, we are good to go. Dr. You can proceed.
All right, okay. Fantastic. So yes, so today, the topic of today is breast cancer. So it is October, and October, as we all know, is Breast Cancer Awareness Month. This is one of the biggest and the most common cancers that affect human beings and that affect women more so. Can you ensure that your mics are muted?
This is really good to from. I think that's bad.
Sorry about that. I'll mute. Let me mute all participants. I mean, sorry about that. Okay, Dr. You can now unmute.
You can see my slides though.
Yes, we can.
Right. So, wow. Okay. Right. Yes. So, what is cancer? Cancer is a group of diseases, of course. Okay. So, essentially, anything that grows, or let me put it in this sense: each and every cell in your body is supposed to grow. The same way your ears grow from a little child ear to like an adult ear is the same way each and every cell in your body is supposed to grow. But in each of those growth cells, essentially it's supposed to follow a certain sequence. So when the growth is dysregulated, that is when now we call it cancerous growth. Right? So essentially, cancer cells are not normal cells. They're just normal cells that are now growing uncontrollably. And now in that uncontrollable growth, that is when now they end up pressing on other structures. They end up invading other structures. They end up encroaching other structures around them. So essentially, in the bare minimum way of explaining what cancer is, that is how I can best use the best analogy I can use to explain what cancer is. So essentially, it's just a growth of cells that is just uncontrollable. It's unruly. It's like those sad to say, the adolescents who cannot just be controlled at all. So that is the way cancerous cells do act. So they start at a point, or they start at any particular organ. There is, I think, scientifically speaking, there are only like 3 organs in your system that cannot form cancer, and these are the dead cells: your hair cells, your nails, and I think it's your teeth. So those are the only 3 things in your body that cannot be affected by cancer. All other tissue, whether it's your eyes, whether it is your skin, whether it is your pancreas, your stomach, all of it, as long as there's growth, they will be affected with cancer. All right. So it can begin at any organ or tissue in the body, and then it often spreads to surrounding or distant tissues. And now, even when we speak about the signs and symptoms, that is when now you'll understand the reason as to why I kept on emphasizing on the encroachment or on the surrounding systems around them. So yes, so cancerous cells are abnormal and they grow rapidly, after which they invade the neighboring and distant tissues. So the neighboring cells, of course, will be affected because it's like a tree that's spreading, or it's growing or spreading the roots around it. But then remember, they can also spread to other organs. And when they spread to distant organs, that's when we now call it metastasis. For instance, if you have now like breast cancer, uncontrollable growth of the breast tissue, and then you end up seeing those cancerous cells maybe in your liver or in your stomach or in your bones, then that is what we call metastasis. Of course, those are just the different ribbons representing the different cancers that you do have. So yes, breast cancer is, fun fact, it's one of the oldest known cancers in history. As you can see, one of the earliest recorded cases dates all the way around back to 1600 BC, which is an ancient Egypt. It was described by that extraordinary young man called Edwin Papyrus. And what he noticed was it was a bulging or a mass on the breast, of which at that particular time, he concluded that there was no treatment for that particular breast disease, which is now contrary to what we do have now. We have a lot of diagnostic modalities. We have a lot of treatment modalities in terms of breast cancer. So in 1991, again, a fun fact, there was during an event, Susan G in New York organized a bit of handouts in terms of pink ribbons. So she was handing out pink ribbons to participants to promote breast cancer awareness. And that is that's the reason why now the color of breast cancer in terms of the ribbons for cancer is pink. She used the pink ribbon that she kept on handing them over. The following year, she did the same thing, and then now the media got hold of it, and the media now propagated the whole pink ribbons for breast cancer. And now that is why we've always gone with the flow for pink being the ribbon for breast cancer. The color pink was chosen intentionally because, again, like you can see on my slides, it's often associated with nurturing and compassion, a lot of positivity, and often symbolizing the strength and solidarity for women and a hope for a cure. All right. So it's something that started way back. It's just that we did not have a lot of diagnostic modalities. We did not have a lot of intervention modalities. But right now we are very lucky. There's so much. And yes, there's so much about in terms of the management of breast cancer. When we look at the epidemiology, in 2022, there were right about 2.3 million women who were diagnosed with cancer, out of which 670,000, this equated to right about 670,000 global deaths. All right, this is in 2022. We're just in 2025. I'm yet to get the exact number as of 2024, 2025 here. But yes, as recent as 2022, you can imagine 670,000 global deaths. And breast cancer, again, is the most commonly diagnosed, is one of the most commonly diagnosed cancers in Kenya, with approximately 6,000 incidents annually. When you look at the right, I think I've put there a pie chart that now signifies, and this is on Kenyan statistics. It's not based on American statistics. It's not based on Ashkenazi Jews. This is now on Kenyan statistics. And if you can see, right about the breast cancer in pink takes right about 16.1% of all cancers diagnosed, which is right about 6,799 cases annually. And then you can see the cervical cancers coming in second at right about 5,236, which is still a lot of cases. And this also hurts me a lot, taking in mind that cervical cancer is one of the cancers that has a vaccine to it. All right. When you look down the prostate in terms of the teal color, prostate is right about the third there at 3,412, followed by esophageal cancer, which is the food pipe, yes, right about 2,974, then colorectal at 2724, and now the other cancers, now the skin cancers, the melanomas, and all the rest now fall, the leukemias now fall under the rest. Of course, there's still a majority, they're still one of the highest cancers. But yes, as you can see, breast cancer is still at a high, at a rise. All right. So in right about 100,000 women, for those ones of us who like research, we can actually say that 34 are likely to have breast cancer. And this translates to right about 2,500 deaths annually. This is a lot of deaths, if I may so say. So what exactly is the breast? For those of us who do not know, I doubt it though. So the breast is essentially this whole tissue, if you can see my cursor, all right? Right down from the clavicle all the way down to the sixth intercostal space, which is now just the rib space, all the way up. So if you can pay attention to where my cursor is, there are little green structures written as lymph nodes. All right, so these lymph nodes are like the garbage collectors to your system, to your breast, and to each and every part of your body. So the breast, being just like any other tissue, essentially has its function, all right? So, and if you look carefully, there's a nipple here, and then there's something here that looks like a lollipop, all right? So there's a stick here, and then there's that bulging out, if you can follow my cursor. So this is from an anterior view, from a front to looking at you from an anterior point of view. From a side view, this is how the breast now looks. Remember, the breast is a modified sweat gland, all right? So it's a modified sweat gland. It's able to produce a lot of things. For those of us who are breastfeeding, it's able to produce a lot of milk for our children, all right? So essentially, this, let me start, kindly mute your mics.
Amanda, you're also muted.
Sorry, I've been speaking to myself this whole time. Sorry. So where did you guys lose me? Hello?
Right after, Dr. Right after we were slightly interrupted. So maybe you could just go back to
Okay.
Somewhere between the ribs and the clavicle.
Okay. Oh wow, that's far back. All right. So essentially, the breast tissue starts all the way from your clavicle, coming right down. This is still the sternum, this bone over here, and all the way down to the sixth intercostal space. This is in terms of your ribs. All right. So it usually comes and encompasses all this matter. All right. Remember, the breast tissue has an axillary tail. When I mean an axillary tail, you see right about where my cursor is. This is where the tail end of the breast tissue usually is. And if you can notice, majority of these lymph nodes are right there. Take note of the lymph nodes that I'm talking about because these ones form a very essential basis in terms of breast cancer. These lymph nodes essentially are the garbage collectors. Let me call them the garbage collectors. In every factory, there are waste products produced, and those waste products are the ones that now, if you want to tell whether the factory is producing good things or bad things, those are the things that you test for. And essentially, this is now the basis of now the screening. If you want to see if you've noted a lump, if you've noted those kind of things, these are the bases where we now come and pluck maybe one or two and then now screen them in terms of are they having any cancerous changes. Again, like I said, the breast tissue is composed of the nipple, as you can see, the areola, which is that darkening, the dark region around the nipple. Again, if you can follow my cursor, there's a line here and then it bulges out at the back end. And you can see very numerous amounts of them. So this line represents the ducts, all right? And then the bulging at the very end represents where now the lobules. We call them the lobules and the ducts. So for any pregnant woman or for any breastfeeding woman, the milk is produced in the lobules and then it travels down through this pipe system all the way back to your nipple, all right? So take note of that because when you're talking about the different types of breast cancer, it will essentially affect that particular route. All right, so this is a side view of it. So again, this is where the lobule, where the milk is produced, and then the ducts, which are the piping systems connecting all of them. And I apologize again for having cropped out the image. The ducts now connect it all the way to your nipple, and then the child is able to suckle. Again, remember, 80% of the breast tissue is just essentially fat, all right? So this yellow golden substance is now the fat tissue. And remember, there's still muscles that lie behind it, all right? Good. So when you talk about the risk factors of breast cancer, there are so many. I don't even know where to start from. I just know there are very many risk factors for breast cancer. But I think I will start from age. I think I'll start from down here and then now move as I move up and anti-clockwise. All right. So age, regardless of the cancer, the type of cancer, age is always a risk factor. As long as you're aging, as long as your cells keep on dividing, the risk of them undergoing a mutation because of the aging bit is also very high. So regardless of which cancer it is, an increase in age is obviously an increase in terms of risk factors or in terms of predisposition to any particular form of cancer. Unfortunately, as it is, that is just the case. Again, in medicine, there's something that we call a previous history of anything. So if you have a previous history of a malignancy or a cancer, you are, of course, at an increased again. Not can increase and this breast density just comes with a lot of remember the breast grows from hormones, the breast grows from estrogen, the breast grows from okay Can you hear me, guys? Hello?
We lost you for a few seconds there, Dr. The connection, your internet was lost, but now we can hear you. Now you're back.
Okay, fantastic. All right. So I was saying some inflammatory diseases of the breast can also can lead you to get some forms of breast cancer, including things like Paget's diseases of the breast. Again, increase in breast density. Remember, the breast tissue grows from hormones. They grow from estrogen, they grow from progesterone. So of course, any increase in terms of those hormonal predisposition can also increase the breast density. The bigger the breast, sometimes, and don't quote me, but yes, in terms of breast density, those of us with a lot of breast tissue, essentially, there's some studies that have been shown they're likely to be predisposed to a lot of breast cancer, right? This is not to mean that if you have little breast density, you will not be having it. Again, family history of breast cancer comes in very handy. Here, unfortunately, if you've had a family history of breast cancer, maybe if your mom had it, you're probably at a 2-time increased risk of having it. If your twin the more genetically similar you are to somebody's genes, all right? So if you have an identical twin sister and she got breast cancer, chances are you are already at a very increased risk of actually acquiring it. In terms of race and ethnicity, again, a lot of studies have been done with the Ashkenazi Jews. A lot of studies have been done with a lot of other people. And unfortunately, in terms of the African demographics, we are now starting to do a lot of research in terms of what genetically in the African gene predisposes us to that. But yes, of course, it has been shown that yes, the Jews and the Ashkenazis have a lot of predisposition to that. Again, older age, I've already talked about it. Female sex, yes, this is already a risk factor simply because we have the female hormones, the estrogen, the progesterone, like I said, they all come in here. Now, again, a point to note is that the increase in terms of estrogen exposure, all right? So if somebody started their menses at right about 15 years, and the other person started their menses at right about 25 years, and both of them got their menopause at 40, it essentially means that the person who started their menses at 15 years already has a 10-year more estrogen exposure to the person who started at 25. So of course, in terms of predisposition, the one that has a more window in terms of you started your menses early, you got your your postmenopausal or your menopause late, then of course your estrogen exposure window is very high. And of course, now that again predisposes you to breast cancer, as opposed to now the counterparts with a little or a little less genetic risk factor for breast cancer. In terms of reproductive history, and this one I have to emphasize, and my counterparts and colleagues here who are women on their careers, and you do not want kids. We are, the Gen Zs who do not want kids. We are the millennials who do not want kids. We don't want any responsibilities. Again, I'm here to unfortunately break down some unfortunate news for you that your reproductive history, any woman who has not been pregnant before is at an increased risk of breast cancer, unfortunately, as it sounds. Yes, you're at an increased risk of breast cancer because when you're pregnant, you tend to have a pause in terms of the hormones. So for those 9 months, you tend to have a bit of a pause. So if you don't have it, then that essentially means your whole life you never had a pause. So essentially now it already now predisposes you to now again the cancer, the hormonal predisposition in terms of years to breast cancer. It's unfortunate, but that's just how it is. All right. All right. So if you can get pregnant, please do. And if you can afford it, please do. In terms of physical activity, obesity, alcohol consumption, nutrition, this one's go without saying. This one's cut across all cancers, all cancers, whether it's colon cancer, pancreatic cancer, all of them. In terms of oral contraceptives and hormonal pills, it's a bit debatable. I think that is something that, again, research is still yet to prove in terms of what is the exact number, what is the exact percentage in terms of predisposition, but there have been stipulated accounts of oral contraceptive pills predisposing people to breast cancer. So yes, how do you know then you have breast cancer? So breast cancer comes in a myriad of ways. Remember, not all patients are textbook patients. Some patients will just come with a bit of a pain. Some patients will come with, Daktari, I have a lump. Some patients will come with, Daktari, my left breast feels bigger than my right breast. So there's so many different ways of presentation. I can't say there's one that cuts across all, but a majority of them will always, most of the time, have a lump. And by a lump, if you know a pea, peas like that, the cereal, peas, beans, those kind of things, majority of the time, they usually tend to be as small as that. So when you touch your breast, and allow me to just call them boobs, if you touch your breast and you feel some form of like a pea-shaped kind of thing, remember the lymph nodes that we talked about? If you can remember the first page, they were looking, actually, they were in green and they were tiny. So if you feel anything of that sort on your breast, please come to us and we will take good care of you. Again, nipple pain, like I said, sometimes it might just be as simple as just pain. You don't know where the pain is coming from. You did not hit yourself with anything, but you're just feeling pain. So again, this is another call for action. Again, changes in skin texture. When the skin texture changes, remember, if you know how an orange looks like, sometimes it kind of has a bit of dots. Or for the ladies, if you know strawberry skin, or if you have any of those, if you've shaved your legs for anybody else, and you see those kind of small dots. So if you see those kind of things on your breast, remember, please, this is one of the biggest symptoms of breast cancer. And remember this in terms of the nipple discharge. Sometimes you can have discharge in terms of very many things. It can be bloody, it can just be serous, which just means clear. It can be crusty, it can be honey crusty. So whichever it is, whether it is green, whether it is red, whether it is clear, whether it is yellow, please, you're not supposed to have this kind of discharge from your nipples. Again, if you see this, the nipple for this lady here, it kind of looks like it has retracted back. It's going back. Instead of being pointy and being pointy outside, it's going back inside. So this again is another symptom of breast cancer. This again is part of those lymph nodes that we're talking about. So, and majority of the time, they're usually on your armpits. So when you go today and shower, this is something that you need to really take good care of. All right. So how do you screen for breast cancer? The first bit is just self-breast examination. I cannot underscore the importance of this. All right. So the self-test breast examination is very important. And ladies, today, even when you go home, I want you to just allow me to just say, remove your clothes, stand in front of the mirror, and just admire the beauty that all womanhood has to bring to you. All right. So stand in front of the mirror and look at your breasts. Remember, both your breasts are not going to be the same size, all right? So there's one that's usually bigger than the other. The nipples, again, there's one that's usually bigger than the other. So just look at the contour. Do they look symmetrical? Do they look normal? Are the nipples well pointy or are they retracting back, all right? Put your hands akimbo and then just take in a deep breath and in and out, and that just look. Do you have any dimpling? Do you have any dimples? The same dimples like you have on your cheeks. Do you see any of those things? Like in this case, if you can see the second one, yeah? Again, are there any changes on your skin? Is it red? Is it black? Is there any kind of skin changes? Again, now raise your arm up and check. Is there any form of does this apply to men as well in terms of yes. I cannot underscore the importance of this. Remember, breast cancer does not necessarily mean it just is in women. It can be in men. And the most unfortunate bit is that when breast cancer affects a man, it's going to be more aggressive and it's going to be actually quite difficult to deal with as opposed to when it affects a woman. So yes, all this still affects the men as well, all right? So the next thing you're going to do is you can either choose to go up and down. You can either choose to go up and down in terms of the breast examination. And I think I will do this for those of us who will be available next week on Friday. So we can do this together. So you can do up and down, or you can do in circular motions, all right? Do not use the tip of your fingers. You use that fleshy bit of your fingers, all right? And I will show you this. You see how this lady is doing? The lady over here, she's not poking it, but she's using this other pulpy bit of her fingers. So this is what we mean when we say that. For those of us with a lot of like the D cups or a lot of breast tissue, you can support. You see the way she's supporting hers so that you're able to feel all that, all right? All right, what is the second bit in terms of the screening? We call it an ultrasound. For those of us who don't know what an ultrasound is, I put this particularly here so that you can see what exactly it means when we say come and screen. So the first thing, as we've already alluded to, is the self-test breast examination. The second thing is the ultrasound. And if you can see, the ultrasound is just this, a little probe over here. So this probe is going to help me define the structures that I've felt with my fingers. They're going to help me define, is it more in keeping with cancer? Is it more in keeping with just a simple cyst, which I will show you later on what it means? Yes, all right. So if you can see, this is essentially what is required for you during an ultrasound. Just come, you remove your garments upstairs, and then we now put the probe and we now start investigating and looking around. What I am looking at as a doctor is now these images that I have clearly put here for you. If I see things that are ovoid, if I see things that are round like this, and if you can see, this is quite black, all right, inside. Essentially, this just means it's a cyst. A cyst is just a fluid very clear. This is most of the time not cancerous. But when I see this, I see very irregular borders. I see it's taller than wide, it's irregular, it's very mixed. Then I start questioning a lot. And it's these patients that I now start saying, we need more imaging to it. What more imaging? Now, point to note, if you're less than 40 years, then the ultrasound is the best imaging modality for you, because less than 40 years, you still have a lot of breast tissue, all right? So this is the best imaging modality for you. However, if we do find this inconclusive, then we move to the next particular bit, which is the mammogram. I'm sure a lot of us do not know what a mammogram is. A lot of us have never done a mammogram. So this, I put this particularly here so that it can show you what essentially a mammogram is. So this is an imaging modality where we are putting the lady, thank you very much for that. The lady stands there, and then the breast is now put in between these two plates, all right? So we are aiming at getting an imaging, a clearer imaging, and it also tells us where exactly on the breast tissue it is. Is it on the anterior? Is it on the apex? Is it on the lower side of it? And as you can see, this is essentially all that is required from you. So you just come, you stand over here, and then you'll be assisted in terms of the imaging. And for me, you can see such beautiful images that I can see, and I can already tell that this is a patient that needs more intervention. This is the patient that needs, like, if you can see, this is the traditional mammogram. This is the initial one. So if you can see, there's a lot of speculations, meaning there's a lot of sharp things going around. It looks like a star kind of thing. So already I know there's a problem here. And if you look at now the newer technology in terms of the 3D, all right? The 3D technology is able to even tell me and define it even further. If you can see, it's very well defined here. So these are the patients now, after which now I call for a biopsy, all right? How do you do a biopsy now? We do a biopsy in terms of, first of all, you have to have an ultrasound probe, this one, which will just help in terms of guiding me. If you can see, this ultrasound is just guiding me to see where exactly is the lump and where exactly should I go and collect the tissue, all right? So I want to collect the tissue exactly at the core of it, all right? I don't want to collect things that are outside here, which will give me a lot of false negatives or false positives. I want to collect exactly at the lump itself so that it can give me a more accurate representation of what exactly is happening on your breast. So this is what happens now when you find a lump. All right, I hope you are clear until there. Please don't be scared. It's not that painful.
We lost you, Dr.
Stages. Hello?
Yeah, we lost you the moment.
Yes, you can.
Yeah, so you could start on this slide.
On the slide. Okay. So in terms of the stages of breast cancer, stages of cancer are just the same. So it stands all the way from 0 all the way to 4. All right. By 0, we mean there are no abnormal cells. Remember the ducts, remember the lobules that we talked about where milk is produced and then where it travels through. So all of that are well in order. So there's no cancerous tissue that has been noted. Chances of survival, of course, are 100%. You're more likely to die of something else other than breast cancer. All right. Then we move to now stage 1 breast cancer. If you can see, the cancer is in the breast tissue, and the tumor is usually less than 1 inch across in size. Usually we use yes, so it is well confined. If you can see the red bit, so the red bit, we used it as to signify the cancerous tissue. So the cancerous tissue is confined within the breast borders. Hydra from the breast, it is well within the breast tissue. All right. Then when you move to stage 2, remember stage 1, it confirms you write about 98% chances of survival, which is still good chances, all right? So that is why we emphasize the screening bit. We emphasize calm screen because you see your chances of survival are still high. When you move to stage 2, now the easiest way to remember stage 2 is usually the rule of 2. So the tumor size is less than 2 centimeters across all sides, and it has spread now to the lymph nodes. If you remember the garbage collectors, now it's going to the garbage collectors right there. If you can see, there's one on the breast tissue and there's one on the garbage collectors. So essentially, these are the people who, if we take the lymph node or a lymph node biopsy, we will be able to see the breast cancer tissue there. Again, remember, chances of survival, 88%. These are good odds, all right? When we move to stage 3 now, the tumor is now larger than 2 centimeters. It has spread widespread through the whole tissue. We're starting to see a lot of changes in terms of the consistency of the skin. We're seeing a lot of dimpling, like that orange skin appearance. It is just spreading outright. If you can see, there's one here, there's another one here, there's another one here. It's spreading. And now you see there's possible dimpling, the inflammation or skin color change. Chances of survival, again, we're going down, we're moving down. I don't like this staircase where we're moving down. Now we're at 52%. All right, at stage 4, now the cancer has spread beyond the breast to all the nearby areas. Remember when you talked about metastasis? If you can see, this is just a reflection of your liver now. It's going outside the breast tissue. It's going all the way to your bones. It's going even all the way to your lungs. This is the unfortunate bit about it. And remember, the breast is so close to your lung that majority of the metastases actually go deeper into your lungs. And this, again, unfortunately, chances of survival are right about 16%, all right? So that is why we emphasize, if we can get it from these places, if we can screen and get the breast cancer at this stage, it becomes very easy for us to handle and deal with it, all right? It becomes very easy. The diagnostic modalities are there. The therapeutic modalities are also there. So it becomes very easy to deal with it at this particular stage, as opposed to stage 3 and 4, right? In terms of management, now, depends on the stage again. If it was just a small lump, then we just remove the lump and we call it lumpectomy. The lazy doctors in us comes out here. If it was just confined, well confined to the breast tissue, remember the stage 1, then we do a simple mastectomy, all right? If it was right about stage 2, remember we had some bit extending to the lymph nodes, then we do a modified radical mastectomy, which means removing the breast tissue. And remember, there were some muscles underneath it, so we leave the muscles intact. So we just remove the breast tissue, all that fats, all that, and then the lymph nodes. And then the radical mastectomy now, if it was really, really encroached, now we also remove even the muscles. If you can see, you can even now see the rib cage there. Yes, there are other forms of management in terms of chemotherapy and radiation therapy. So the difference between chemo and radiation is that chemo uses medication to kill or target the cancer cells. As you can see, it's just usually an IV drip you put, and then it goes and targets all the way to your cancer cells. So in terms of chemotherapy, this is where now we use those estrogen or hormonal sensitive material, the tamoxifen, for those of us who've heard of them. Yes. In terms of radiation, now we are using beams. We are using beams, high energy beams, to now kill the cancerous cells. So here it's not, you're not being poked, you're not being done anything. It's just the beam of radiation that now targets the cancer cells. And that's the difference between the two. Now, you can get both, and that is something we call neoadjuvant therapy, or you can get it after the surgery, all right? So when you get it before the surgery, the aim is to just reduce and shrink so that when we go in as doctors to remove it, it's a small bit that we are removing. When we get it after, now it's just for remission. Now we are aiming at remission. We're aiming at it killing the remaining cells that we might have not gotten. In terms of prevention, goes without saying, eat healthy, regular exercise, do not smoke, and especially tobacco. Please, guys, please, 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 let's leave this thing alone. My professor, and I always emphasize it in university, used to say, even if you don't know the answer to the cause of a cancer, any cancer in your body, just say cigarette smoking and you're assured of a mark, you're assured of a point. So that is how bad cigarette smoking is. Again, limit hormonal therapy. This is a bit debatable, but yes, if we can limit it, let's limit it. If we can use the natural ways, that's fine. Limit alcohol, again, goes without saying, and weight control. Fun fact about weight control is that, remember, majority of the time when you're, for the ladies who are a bit plump, the ladies who are a bit on the excess bit, they tend to have a lot of fatty tissue, all right? So that fatty tissue, that peripheral fatty tissue in terms of your skin, can be converted to estrogen. And that is why, and remember, the cancer cells is feeding from estrogen. So if you're already on the other excess end, and that fat is being converted to estrogen, then again, it predisposes you to breast cancer. Just a few myths and misconceptions at the end, which I think I put them on as to part of the questions. I don't know whether you guys were able to see together until there. Let me see if I can get a hint of the questions. If I can project it. Is there any question in the meantime, or any clarification that anybody needed? Hello.
Amanda, let me just
Yes.
help you go through the
Hi, I think this is Joyce.
Yes, Joyce.
Yeah, sorry, we joined in late because we were having another concurrent meeting running at the same time. So my request would be just maybe that the Liaison team would share the recording so that we can at least get the information that was shared before we joined. Thank you.
Okay, all right. That is very well in order. Thank you so much for that, Joyce. We'll make sure I'll share my slides with you. Really good awareness. Kindly share the slides. I shall do that. Just that, James. Thank you very much, James. Wow, that's good. Are you on anesthesia when getting the sample? Yes, of course, you have to put you either it's local, depending on the size. Yes, so you will get anesthesia before we do the sample. We are human. We are it. So how long, generally, on average, does it take for one to move from one stage to another? Very good question. Who is this? Isabel Juma. Very good question. So in terms of the predisposition or the progression, rather, it varies from patient to patient. I cannot lie to you and tell you it will probably take you 3 months, or it will probably take you. There are a lot of factors that go into it. Number one, your host immune factors, right? Host immune factors plays a very, very huge role on this. So if you're somebody who is probably immunocompromised, if you're somebody who has maybe, I don't know who that is, but yes, kindly mute. Kevin? Right. Yes, so there are a lot of factors that can influence this. If you're otherwise not having any other forms of underlying conditions, no diabetes, no hypertension, no any other immunocompromising factors apart from now that cancer, then of course the progression might be slower. All right. But if you're somebody who, again, depending on the type, of the breast cancer that you have, it will dictate which one. There's some that usually progress faster than others. There's some that progress slower than others. So yes, it depends on a lot of things. It is very individualized. It is very subjective. I cannot generalize it. Collins asks, why is chemo painful? Are there any remedies to the pain? Chemo is painful. Yes, I know it's painful. It is draining more than it is even painful, simply because of all the side effects that it has, unfortunately. Chemo is one of those medication or one of those treatments that has a lot of widespread side effects. But now you see, when you weigh the pros and cons in terms of survival, it is much better to go through it. Again, unfortunately, that is just the case for chemo. I cannot really say much about it, but the pros obviously outweigh the cons in most cases. Clara says, how frequently should one have a mammogram done? So in terms of the frequency of mammograms, remember, if you are above 40, then a mammogram is actually recommended for you. Yes, so if you're above 40, maybe twice after every 2 years, that is usually the plan. But again, remember, Clara, if you do realize any form of thing, do not wait for the 2 years to say, Dr. Amanda said, you have to wait after 2 years for you to go back. No, if you notice anything, please, at that particular point, just say it and come and seek medical attention again. So usually just, if you can do it, if you can afford to do it yearly, why not? Most of the first world countries are actually doing their medical checkups, including imaging, yearly. So that is why majority of the time for those first world countries, we deal with those things very early, we get them very early, and the options that we have are very, very many, right? I see James Conde has asked another question. Dr. Is there a situation where these symptoms come and go, such that one can assume, and for how long? Yes. And actually, there was a friend of mine who kept on having this kind of impulsive kind of growth of breast tissue. Remember, the breast tissue is very cyclic. So you have menses every other month. So sometimes you can tend to feel the lump more pronounced as opposed to other times during the month. So those are some of the situations where you can feel like sometimes it is very pronounced, and then other times of the month it's not as pronounced. So yes, it can happen. I've had it happen. For how long? As long as you're a lady, as long as you're having those menstrual cycles, as long as you're having those estrogen, progesterone cycles, then it can happen for quite a while until you get or you reach menopause. So yes, it's just do your due diligence. In case anybody tells you about it, encourage him or her to actually go to the nearest facility and have it checked. Does having a non-cancerous breast lump removed at a young age increase the risk of developing breast cancer later in life? And how can one best monitor the breast health in such a case? All right, this is a very good question, Rachel. In terms of non-cancerous breast lump removed, remember, as women, we tend to have the majority of causes of breast cancer, of breast lumps in young people are actually not cancerous. We call them fibroadenomas. So majority of us have fibroadenomas, all right? So these things tend to happen a lot. Yes, in some instances, less than 2% of the cases, they can convert into breast cancer. But yes, having them confirmed pathologically that it is not cancerous is a good thing. Already that already tells us that it is you're not at an increased risk of having breast cancer from the pathological review of it. How can one best monitor their breast health in such a case? Take note of any changes, take note, listen to your body. Your body never lies. So just listen to your body. Do your self-breast examination. In the event that you're doubting yourself, call a medic, call a nurse, call a doctor, and have them examine it for you. If you can get an imaging modality, even better, because now that gives us a clearer picture of whatever is happening. How can men check for breast cancer? Same, Jema, same. In the same sense as women also take note of those lumps on the armpits. They take note of the lumps on the breast. They take note of any of those pain or any of those changes on the breast. It's the same case that applies for men. If you feel like you have noticed anything, any lump, then again, the ultrasound is still the first step. It doesn't change whether you're a man or a woman. It's still the ultrasound. Mammogram, maybe not, because we don't have a lot of breast tissue for you to squeeze onto the machine. But yes, Ultrasound, yes, and then now we can now include other further imagings like MRI scans, the CT scans. Good question. Just mention that people who are about 40 years should at least go for a mammogram twice a year. What about people below 40 years? Yes, that's a very good question, Hava. So in terms of the screening, like I said, we usually put us less than 40 for ultrasound, above 40 for mammograms. Again, if you can do it even yearly, it's fine, it's okay, because remember, we never know. Sometimes there's some of those cancers that, again, progress quite fast. So you might have had an ultrasound done maybe last year, but after 6 months, you develop something. So it's at that point that you just go and screen for it. If you can do it annually, well and good. Even better for us. If you can actually do it annually, well and good. An ultrasound is right about 3,000, 3,500. That's good. It's cyberknife radiation also used for breast cancer. Now, I'm not so sure about it in terms of breast cancer, in terms of whether we are using it in Kenya, but yes, as long as it's a good kind of radiation, yeah, it can be used, right? I know it's just it can be, as long as it's still radiation, yes, it can be, and as long as it can still target the cells that it's supposed to target, then not so sure whether we use it currently in Kenya. I cannot really tell that for now, but yeah, I know it's being used somewhere in the UK. I remember in Amsterdam, yes. Clara, after menopause, does the risk of breast cancer end? Oh, this is a very good question. Oh my days. So Clara, unfortunately, like I said, one of the biggest risk factors of breast cancer is age. So in as much as yes, you might have not have had like a very huge exposure in terms of years of breast cancer, then the age factor still is there. So in as much as I may want to say no, I cannot really say that. In research, we say the risk only ends when somebody dies or when somebody, unfortunately. Are you providing a free screening this month? If so, could you please share the date and location? Very good question for this. I think it shall be confirmed, but it was supposed to be tomorrow, but since it is a public holiday, I think we shall move it to probably next week on Friday at the address, right there at the address, at the parking lot. We shall be there as hired, and we shall come in handy for those of us who want to have those of us who want to have the imaging. Please also communicate early so that we can have the sonographers on ground on site, especially for those of us who would want to have it screened and done. Yes, so just communicate early and then let us know. Yes, I think that's about it. In terms of myths and misconceptions, yes, men can also get breast cancer. If no one in your family has had breast cancer, can you still get it? Yes, you can still get it. Does wearing a bra or using deodorant cause breast cancer? No, there is no scientific linkage towards that. Breast cancer always forms a lump you can feel. Not all breast cancers form a lump that you can feel. All right, Janet, I can see, where is your clinic? We're located at the KMA 6th floor. So you can come there. KMA 6th floor. Let me just type it on the chat box. Yeah. I think that's about it. Are there any other questions? Do you really heal? Do you really heal from breast cancer after treatments and all? Yes, you do. And right now, Brenda, there are even some other forms of reconstructive surgeries that we actually do. So sometimes you can remove the breast tissue and then we put in some silicone bits of it. And then we also even tattoo in terms of the nipple. We have a 3D tattooing in terms of the nipple representation so that you end up mimicking a normal breast. So yes, it is possible to heal, Brenda. Can lifestyle choices like diet, exercise really lower the risk of breast cancer? Yes, they do. Diets, things like the vitamin A, C, vitamin E, those kinds of foods rich in antioxidants? Yes, they do. Remember, most of these cancers actually come as a result of mutations or as a result of this oxidative effect. So if you do eat a healthy diet, if you do exercise, they really lower your risk of breast cancer. So Cynthia, yes, they do, and a lot. Remember, we also talked about the issue of weight on breast cancer. Remember, that is very important for us to remember that your peripheral fat can be converted to estrogen, which can again increase your estrogen exposure in terms of breast cancer. So yes, lifestyle, yes, they do. Thanks for the informative session, Doc and the Liaison team. Thank you so much, Collins, for being here. Wow. This was so informative. Thank you so much. Thank you so much, David. I believe in urban areas, James, it's easy for us to get this awareness, but I'm worried of very rural communities where, okay, I'm also worried about them. Do you have time that you can schedule a conduct outreach? Yes, please do reach out to me, James, and we can schedule for this. Again, remember some of these things, the new technologies that are coming up in terms of the blood work. So sometimes you can have the blood work investigating the metabolites or the waste products from the cancers just from your blood sample. So these are novel ways of diagnosing some forms of these cancers, which are very, very accurate. We're doing a study with Biomac, which is a Canadian company, on this, as well as Cambridge currently as we speak. So maybe next year's wellness, we might want to include that. After one goes through the treatment, chemo and radiotherapy, and is declared cancer-free, can it come back? Yes, it might come back depending on the aggressiveness of it. Yes. So Manu Rose, so unfortunately, that's just the case. Sometimes it can come back. I think I'm short of time. In case anybody wants to reach out to me, please do so. I shall leave my number there. Miss Yvonne, I think the questions are so many. Wow.
Yes, and I think we can give you like 5 more minutes just to finish up, because I can see there's a question here from Evelyn. So I think we can answer that, and then in case there's anyone who has a question, they
Where
can
can I
raise
get
up their
tested
hand.
for gene and how much? Evelyn, this is a very good question in terms of the genetic testing, the genomic testing. They do work in Kenya. There are a lot of centers in Kenya, and I think I will link you up with a few of those centers. A bit on the pricier end, but yes, there are some areas in Kenya that we can actually have the genomic studies done. So if you want, you can reach out to me and then I can let you know of them. Boresha, if you feel a lump and you've undergone MRI test and found that it is not active, not cancerous, can I still get worried? Not really. Usually I tend to say if you get a lump, the gold standard is usually to get a biopsy of that lump. All right. Because the MRI will just tell me, yes, it is like this. In terms of the imaging modality that can tell me whether it's cancerous or not, it's a PET CT scan and not an MRI scan. But yes, if you get a biopsy of that particular lump under a microscope, that is a gold standard. Can a fibroadenoma get worse? I don't know what worse means, but can it grow? Yes, it can. Can it transform into a cancer? Like I said, right about 2%, not so much in terms of the risk predisposition towards cancers, but yeah, it can 2% of the time, but yeah, not really much from fibroadenoma. Any other question that I can attend to? So in case anybody wants more clarification, feel free to reach out. My number is right there. You can come to ours as well. Feel free to walk in. And yeah, I hope I've been helpful. Does fasting contribute?
We lost you, Dr. Dr. Amanda?
Yes, I can hear you.
Yeah, we lost you.
All right. I was just answering Boresha's question. Florence's question, does fasting contribute to destruction of cancer cells? Not really. Remember, cancer cells are just overgrowing. Like we said, they're just on steroids. They're just growing and growing and growing. Whether you fast or not, the cells are still continuing to grow. So not really much in terms of scientific evidence. I will say no to that for now. Boresha says, does sugar consumption contribute to growth of cancer cells? There's a lot of scientific evidence that needs to be actually proven. So for now, until there are studies that have been shown and proven, I cannot answer to that, but yeah, just maintain a healthy lifestyle, exercise, healthy diet. For now, I cannot really say, I cannot really create a linkage or prove that there's a linkage, direct linkage towards cancer cell growth with sugar consumption. Remember, sugar is everywhere. Sugar is in oranges, sugar is in sugarcane. So I can't really create a linkage, direct linkage for now without scientific evidence to that. Yeah, is there any other question for me?
There's no other question in the chat box. And
Yes.
maybe just before we close up, I think the exercise we did at the beginning, I don't know if you're able to tell us how we answered the questions as
let
we
me see
close.
if I can access let me see if I can access from my phone. But yes, as I was debunking it, I think most of those things. But for now, I can just debunk whatever it was there, like I had started. Myth one was, does only women get breast cancer? And we said no. Men can also get breast cancer, although it's rare. About 1% of all breast cancer occurs in men. Myth two was, if no one in my family has had breast cancer, I can't get it. Fact is that most people diagnosed with breast cancer have no family history. Lifestyle, environment, and random genetic changes also play a major role. Myth three was wearing a bra or using deodorant caused breast cancer. And the fact there is no scientific evidence. Was breast cancer always forms a lump that you can feel, and no, not all breast cancers present as a lump. Some might show as skin dimpling, some might show as nipple changes, swellings, and that is why the other imaging modalities like mammograms and ultrasounds and regular screenings are very vital. Myth five said young women don't get breast cancer. The fact is, while the risk increases with age, young women can and do get breast cancer, though it is less common. Myth six was a mastectomy guarantees the cancer will come back. The fact is, even after surgery, recurrence is possible. And I think there's somebody who had asked that, especially if the cancer cells have spread microscopically, the things that you cannot see with your eyes. So regular follow-up and lifestyle care are very important. I think myth seven was breast cancer always means losing your breast. No, with modern treatments, like I said, many women qualify for breast conserving or conservative surgeries or reconstructions. So early detection usually decreases the options of those radical mastectomies, the ones that you cut across the whole thing. And then myth eight was mammograms cause cancer due to radiation. The fact is the radiation from a mammogram is extremely, extremely low, and the benefit of early detection far outweighs the minimal risks. I hope I've answered all the questions that were there.
Yes, you have, and thank you very much. And I think we're coming to the close of the session. I see no hand and I see no other questions in the chat box, so you'll allow us to conclude the session today. Thank you for participating by asking questions and listening in. You can pass on the knowledge you have acquired to the people around you. We'll definitely be sharing this presentation and the recording as well. So thank you and have a good day. Thank you, Daktari. And as Daktari mentioned, they are located, Maya Kidney Specialist Hospital is located at KMA Plaza in Upper Hill. You will find them on the 6th floor. And Dr. Amanda already left her number on the chat box. Feel free to get her number and reach out and schedule for a checkup, right? Thank you. So there are those who will be at the address. Yeah. So there are those who will be at the address. Feel free to go for the checkup next week, Friday. Those who are not able to, you're free to visit your nearest facility or Maya Hospital at KMA Plaza. So thank you and have a great day ahead. See you next month.
Thank you so much. See you on Friday.
Yeah. Okay.
Thank you.
All right. Bye-bye.
Thank you. Bye.
Thank you. Bye.